this year's Public Health Summer School. And this is actually an extra seminar we put in, and it was really taking advantage of the fact that about 8 months ago we conceived that we needed to have an all-day course on how you respond to an emerging potential global health threat, an infectious threat in the Pacific. And I guess it's a remarkable coincidence that we're now battling the emerging coronavirus epidemic. The format today is we've got two speakers. They're going to talk, and then we'll have time for a Q&A session at the end of that. We'll be finishing about 6:15, and then you're all welcome to join us in the foyer for refreshments, and that will also be a good chance to talk with the speakers. So our first speaker this evening is Professor Nick Wilson. He's Director of the BODE program here at the Department of Public Health at Otago. And he is a public health physician, and for at least 20 years he's had a huge interest in looking at pandemic diseases and their impact on populations. So his focus today is really comparing the emerging coronavirus epidemic with previous pandemics that New Zealand has encountered. So over to Nick Wilson.
Kia ora koutou. So I'm going to be talking really about the comparative epidemiology of this new coronavirus, which has just been given a name, COVID-19, with past, particularly influenza pandemics, and thinking about what are the possible implications with those differences. So looking, first of all, looking at some particular terms to improve our pandemic literacy, looking at the issue of transmissibility, and then the case fatality risk, and implications of these for our potential responses. So first, in terms of defining features of emerging infectious diseases, one of the key ones is transmissibility, and I'll be giving you some examples of what are called reproduction numbers. Then there's the key issue of severity, reflected by the case fatality risk, the risk of death amongst cases, and very relevant to the health service response, the risk of cases being hospitalised. Controllability, which relates to effective, affordable and socially acceptable control measures. In terms of epidemic spread, there's the key terms of what is an epidemic, which is a disease occurring at more than expected levels. Outbreaks, which are really localised epidemics in a particular place and time. And a pandemic, which is referring to widespread epidemic occurrence, usually affecting multiple countries and sometimes worldwide. So in terms of transmission, key issues are the incubation period, the doubling time of the epidemic, and what is typically occurring with a highly transmissible epidemic is a period of exponential increase. Also relevant is the issues of asymptomatic transmission, or before transmission occurring before cases become symptomatic, and if that's occurring, then there'll be silent transmission of infection in the community. And then there's all the issues of control measures, which are very relevant before treatments are identified and before vaccines are available. So there's the issue of isolation, which applies to cases. Unfortunately, we've been seeing terms like self-isolation, where people are really actually engaging in home quarantine. So unfortunately, there's some blurring of these terms, because quarantine really just applies to people who are not identified as cases. There's even a term called protective sequestration, where people are protected by the closing of a border, for example. And then social distancing is a term that's been used, which reduces the level of mass gatherings in public, and maybe school closures, people working from home and so on. And in terms of hygiene, there's hand washing and cough etiquette, sneezing into your elbow and so on. So these are sort of terms which do have specific meanings. And in terms of pandemic control, the relevant phases which we're thinking about at the moment in terms of New Zealand's pandemic plan are the keep it out phase, the stamp it out phase, and then if they fail, the management phase. And all these are well detailed in the Ministry of Health's pandemic plan. And just to give you an illustration of how an outbreak is really a subset of that concept of an epidemic, and the pandemic is the widespread international occurrence of that epidemic. So now thinking about how transmissible some of these past pandemics have been and the relevance to the new COVID-19 coronavirus. So a reproduction number, naught, relates to the risk of one person, how many people do they typically infect. So back in the 1918 influenza, we calculate from a range of New Zealand studies that the average infected person infected 1.2 to 1.8 other people. So that was a pretty infectious disease. There was another influenza pandemic that hit New Zealand in 1957, and that was nearly reaching one person infecting two other people, with a reproduction number of 1.7. The 2009 pandemic, also roughly in that range. There's 3 studies that looked at that for New Zealand. And many studies around the world have looked at seasonal flu and give it a reproductive number in that similar ballpark. But the studies so far on this new coronavirus suggest it is more infectious than those typical past pandemics, in the range of 2 to 3. But there's the way that people have been able to calculate those, there's probably an upward bias, and maybe the true value will emerge to be actually less than 2. But it does seem to be a pretty highly transmissible disease, but still quite a lot of uncertainty about that, given we still have all these lag periods in terms of calculating cases, and also identifying mild cases has been a big difficulty. And in fact, New Zealand might be particularly lucky by it being summer here, because we know coronaviruses, of which many others exist, and some cause the common cold, they really do definitely peak in winter. So transmission of these is much less in summer. So we could be lucky, and we could actually, that could really help us avoid this epidemic being established here. Though the downside is if we delay successful arrival and it arrives in winter, then it may take off actually more dramatically. And if we're able to have good control in terms of encouraging contacts to be engaging in home quarantine, or having them, and similarly with cases isolated through the health system, that is also going to obviously reduce those numbers in terms of transmissibility. And obviously if there's social distancing, reduced public gatherings, if more people work from home. Well, there was some evidence in the 2009 influenza pandemic that working from home really did help reduce community spread. But you can see that in the past, these pandemics, some of them have spread through the community very quickly. So the difference between those two lines is the North and South Island, just a matter of a week before the peak in the North Island versus the peak in the South Island. And that pandemic in New Zealand was just really a matter of 40 to 50 days before it finished. So that was and that was the days of no aircraft. It was just the railway network and coastal shipping. So sometimes, even in that situation, there's very rapid spread. And when we looked at the military population, again, it was in the military in New Zealand, it was a very rapid epidemic in 1918, whereas throughout the whole military spread out in the Northern Hemisphere, it was much more spread out affair. And similarly for the 2009 pandemic, it was really just the winter months in New Zealand, so relatively fast as well. So what is the case fatality risk of these past pandemics? And the 1918 flu pandemic, which killed around 9,000 New Zealanders, had a pretty high case fatality rate in the sort of 2 to 4 range, which was vastly greater than the 2009 pandemic, where really only 1 in 10,000 cases died. So really not greatly different from seasonal influenza. But it's very hard still to establish what is the true case fatality rate for this new disease, because I'm really not trusting any of the estimates from China itself because of difficulty understanding, missing mild cases and the often 3-week delay between a person becoming symptomatic and dying. So there's a lot of information problems with that. But when you just look at the cases outside China, and that's really only 1 death out of 395 cases looking at the WHO report this morning. So only 0.25%. So that is somewhat reassuring. Some of these people who've been travelling maybe are healthier than the average person, but it's possible that there's outbreaks occurring of uncontrolled cases in Singapore and Malaysia and other countries. So actually anticipating that will go down further probably. Also reassuring, this well-studied cruise ship outbreak, only 0 out of 135 people have died. I mean, some are in hospital and may still progress, unfortunately, to death, but that is also reassuring. And also because, from what I know of cruise ships, there's some very elderly people on cruise ships and often very overweight people as well, so that's also reassuring. So actually, some people have pulled all this information together and they think the coronavirus profile is in that range. So this is the infectivity, transmissibility here, and this is the risk of death going up there. So, it's way, way less transmissible than, say, measles, and it's also much less, has a much lower case fatality rate than smallpox. So it is in a somewhat reassuring zone, but there's a lot of uncertainty here, and it could, this range could even be not quite correct. It could even be similar to seasonal flu when we finally get all the data. And there is this complex issue of asymptomatic cases, and the Japanese citizens evacuated from China have been well studied. All 565 were tested, and surprisingly, of the 8 test-positive cases, 5 had no symptoms. So that is suggesting that there is a lot of asymptomatic infection, a lot of mild infection that isn't being picked up, and that's going to influence how we really understand the epidemiology. So this is good from a disease burden perspective, all these people not actually getting sick, but it's obviously going to be harder to identify them and harder to control the disease if there's a lot of asymptomatic people, some of who may be infectious. What is the impact likely to be on the health system? Well, even with a relatively mild pandemic, New Zealand was pretty pressed with 1,100 odd people hospitalised in 2009, and at 100 odd cases in ICU, it really pushed our ICU capacity to the limit. And some of you will remember with the White Island disaster recently, our burns units were also pushed to overcapacity. Some burns patients also went to Australia. So we run our hospital system at such amazing efficiency, we have unfortunately very little surge capacity. But looking at the data, yeah, although there's a lot of mild cases, if you do end up in hospital, actually it's a bit concerning the high proportion of Singapore cases who are in the ICU, and in the Japanese cruise ship off those people who, at that time, there was, in their first 64 identified, 4 of them were in pretty poor condition, apparently. So some of those features are concerning. And the other concern is that, if this disease is bad, it will impact probably on health inequalities. And when we looked at 3 pandemics, Maori had 7 times the mortality rate back in 1918. It got a bit better in 1957, but even in 2009, the mortality rate for Maori was twice that of non-Maori. So that really highlights the persisting problem that pandemics hit our highest need in most vulnerable populations, and we've got to think about that with pandemic planning. So just pulling that information together, what might it mean for the keep it out phase of New Zealand's pandemic plan? Well, it's still very high uncertainty, and because of that, we need to be prepared to intensify, or if that's found to be ineffective, to scale down the controls. But I think the government is taking a precautionary approach, but I think it could be even more precautionary and potentially intensify travel restrictions further and do more in terms of helping people out with home quarantine, supporting them more, and identifying people who should definitely be in home quarantine. And there's now quite a few countries with multiple cases, some of which may have ongoing uncontrolled outbreaks, and we need to potentially factor that in. And I think definitely, it's pretty tough to be on home quarantine for 14 days. We need to think about how we can support those people to make it easier. So what are the implications of the stamp it out phase if we start to get clusters in New Zealand? Well, I think it's going to be very worthwhile to investigate small clusters to see if we can, in this New Zealand summer, successfully prevent this outbreaks taking off into epidemic spread in New Zealand. And it's also useful to test our systems. There's actually, today we had this outbreak session on a much more serious pandemic. And in the future, there could be, with synthetic biology, much, much more serious pandemics. So we should, in a way, take every opportunity to practice using our systems to really make sure we can deal with far bigger threats. And so we should, have a good go at cluster control and the stamp it out phase. And we should even, if it's just one island, we should try and save the South Island. Even if that causes a week of disruption, we may learn a lot about if we can do this in more serious events. But as I said, the reproduction number is high. This is pretty transmissible, at least in the Northern Hemisphere. And so if it's pointless wasting a lot of resources if this is going to be something like a typical influenza, and it's going to be very hard to control. But I still think we should have a good go at it and learn from those lessons. And I think we also should start thinking now about the management phase. We should be intensifying hand and respiratory hygiene practices and really reinforcing that message of staying home when sick. And if widespread cases occur, we need to think about the pros and cons of different social distancing measures. Some of these can have big impacts, cause a lot of burden on the community, but studies have shown that school closures in some pandemic situations do help, and certainly a lot of people now can work from home, and supporting neighbours and all those things will come into play in the management phase. And in terms of surveillance, I think we need to look at extra support to DHBs and ESR so they can conduct good surveillance. We need to maintain and build good links with Australian modelers who are doing a lot of work on studying this current coronavirus situation. And operations research. We need to find out how hard is it to have home quarantine? what sort of supports do people need in terms of, even food and other basic provisions? How can we make it as easy as possible? So to sum up, there really is, honestly, high scientific uncertainty still about the key parameters. It's going to take a while to really nail those down. But from what we know, this is pretty highly transmissible infection. But fortunately, the case fatality rate is lower than some of these other pandemics we've seen. It's probably well under 1%. But that's still going to be a lot of, potentially a lot of deaths. And I think we need to really emphasise that precautionary approach, justifying a heightened response now, but being ready to rapidly move to the different phases in the pandemic plan so that we don't waste a lot of time chasing cases when obviously we need to move to a manage it phase with uncontrolled spread occurring. So yeah, I'll be happy to answer questions in the Q&A session and hand it over to my colleague now.
Thanks, Nick. Really pleased now to introduce Professor Raina MacIntyre, who's Head of Biosecurity Research at the Kirby Institute at the University of New South Wales. We're very fortunate to have Raina here today. She's a world authority on biosecurity and, as we'll hear, also the use of personal protective equipment. She'll also be available to contribute to the Q&A session at the end. So over to Raina.
Thanks, Michael. Good evening, and thanks, Nick. That was a really great talk, and I agree completely with your advice about moving through the phases. Nick was very kind enough to share his talk with me yesterday, so I was able to make sure I didn't overlap too much. But the coronaviruses are a group of viruses that are enveloped positive stranded RNA viruses that infect animals and humans. We know that beta coronaviruses and alpha coronaviruses cause the common cold. They can cause more severe respiratory tract infection in the extremes of age, in infants and the elderly. And also some alpha coronaviruses cause pseudo-croup and bronchiolitis in children. There have been 2 zoonotic coronaviruses that have emerged, in SARS in 2002 and MERS coronavirus in 2012, and this COVID-19 is closely related to SARS coronavirus. If you tried typing in 2019 nCoV, it's really difficult to type, isn't it? Because it's like on extreme ends of the keyboard. So early in the epidemic, the WHO was notified of an outbreak of pneumonia in Wuhan on the 31st of December 2019. Apparently what happened was that the local health authorities identified the outbreak very early in December, and what you've heard about in terms of trying to keep it quiet and so on, that was mainly the local health authorities. But the Chinese have this amazing surveillance system to pick up severe acute respiratory illness signals through emergency departments, and they picked up a signal that something was happening in Wuhan. So when the China CDC came to investigate, they realised something serious was going on, and fairly soon after they notified the WHO. The first symptoms in confirmed cases seem to have happened around December the 8th, and the first exposure at the Huanan seafood market, which you've heard about in Wuhan, may have occurred around December the 1st. Interestingly, though, the index case, the very first case to get sick, was not exposed to that seafood market, and there were a bunch of other cases in that first cluster that did not go to that seafood market. So initially it seemed to be a point source outbreak from the seafood market, and the seafood market was closed on January the 1st. But then there was a constant number of cases, it seemed, from January the 1st till about the 12th to the 18th of January. It was about 50 cases. They say it might be because they were keeping their case definition very tightly restricted to severe pneumonia and not looking for milder cases. But there was a surge of cases after January the 18th. And then, from then on, it's really looked like a propagated epidemic, person-to-person transmission. And as the outbreak progressed, fewer cases had direct exposure to the seafood market, which had been closed anyway. Now, the surge in cases around the 18th to 20th of January coincided with the increased travel for the Chinese Lunar New Year, or Spring Festival. A lot of people travelled to go back to their parents' home or, their family home at that time. And in fact, most of the cases still in the rest of China had a travel history from the Hubei province. China then took the extraordinary measure of locking down Wuhan and other cities on January the 23rd, thereby reducing travel out of the disease epicentre. And they also extended the New Year holidays to February the 9th, which was just this Sunday past. And I don't think we've seen that. We saw lockdown happen in Sierra Leone during Ebola, but nothing to this scale ever before. Currently, there's about 43,000 cases and over 1,100 deaths, I think, at latest count, and about 395 cases outside of China. So the bulk of the cases are still in China, and the majority of those are still in the Hubei province. Now, the best study so far, I think, from which to estimate the parameters that Nick has talked about, including the R0, is this study by Lee et al. From the New England Journal of Medicine, because all the other studies that have been published, including some of the modelling studies that have perhaps prompted some of the mass quarantine decisions and so on, have used the date of reporting of cases rather than the date of symptom onset. And really you need to use the date of symptom onset to accurately estimate the R0. So this study, the dark brown there are the ones that had the exposure to the market. This was the first cluster. And the light brown ones had no exposure to the market, and there's a nice timeline there which I won't dwell on. But you'll notice the first two cases there did not have exposure in the seafood market. So where did they get infected? We don't know. But they estimated R0 to be 2.2, so that is what I would consider the most valid estimate to date. These are some epidemic curves that I've put together myself. This one is cumulative cases, not new cases, cumulative cases split by Hubei district and the rest of China. So the rest of China is in red, the deaths are in yellow down here. And you can see that still the majority of cases have been in the Hubei province. This is actually an epidemic curve based on reporting date, not onset date, because I didn't have onset date. And we've seen here the seafood market closed on January the 1st. The first case outside of China occurred in Thailand on the 15th of January. And then we had the lockdown on the 23rd. This is the 2-week incubation period here from the lockdown, which is where you would expect to see an effect of that lockdown after that 2 weeks, right? Because everyone who was going to get sick would have got sick in that 2-week period who'd travelled just prior to the lockdown. And you can sort of see it looks like it's going down. This is all the new cases. This is the cases in China broken down by Hubei province versus the rest of China. So the rest of China is in green here, and you can see the lockdown period here, the incubation period. And in the rest of China, it certainly seems to have flattened out, which makes sense. If you're stopping people travelling from the affected epicentre to the rest of China, you are going to see an effect after the incubation period. And just about that time, you start to see a decline there. For Hubei itself, though, because everyone's locked in there, hospitals are overrun, there's not going to be much effect, is there, of the lockdown. The lockdown is only benefiting anyone who's outside of the Hubei province, which includes internationally and the rest of China. So I think that provides some indirect evidence of epidemiologically of an effect for anyone outside of Hubei. Now, just to show you the difference between date of onset, symptom onset versus date of reporting, these are two graphs put together by WHO of just the cases occurring outside of China. And this shows by symptom onset, and the other curve over here shows you by reporting date. Because you can get a big backlog of reporting and someone just suddenly makes, 1,000 reports on one day because they were busy doing other stuff. You can imagine that you can get quite a lot of bias when you look at data by reporting date. And that's important because some of the modelling studies that have given us estimates of how long the epidemic's going to go on have used reporting date, not date of symptom onset. Just briefly to mention SARS and MERS coronavirus, this curve here shows the epidemic of SARS. It came and it went in 8 months, had an R0 of about 2 to 3, so pretty infectious, whereas MERS coronavirus emerged in 2012. This is juxtaposed over the same time period and just kind of puttered along like a sporadic infection with a few epidemics here and there. And if I had to plot the COVID-19, it would be sort of, in a much shorter time period, that's 8 months, would be in really 1.5 months, would be surpassing the number of cases of SARS. Has there been underreporting? No doubt there has been, because one point is that if you've been following the numbers on the number of recovered cases and the number of deaths, so the number of deaths is fairly small compared to the number of cases, but the number of recovered are also very low. So why is that? Is there underreporting of deaths, or is there just a very long illness that's causing people to be in hospital for prolonged periods? So the first doctor in Wuhan to report the epidemic was arrested and imprisoned initially by the local authorities. He was later released and he actually got infected. He was an ophthalmologist and unfortunately he passed away last week, which caused a lot of consternation and grief in China. And, it's worth reading up about him. Dr. Wheeling. So this just shows the map from WHO of where the cases are globally and the number of cases. You can see that one thing that seems odd to me after this period of time is that it hasn't had intense community transmission in other countries. There certainly have been person-to-person transmissions in other countries, but it hasn't taken off in the community. The cruise ship outbreak is the largest outbreak outside of China on the Diamond Princess. In terms of exposure to risk factors, in the early cases, 49% had been to the Huanan seafood market, but as I said, the index case had no exposure to the market. They went and tested the environmental, they took environmental samples at the market, 500 swabs actually, and they found 35 were positive for the virus. Now it's a huge market, and although it's a seafood market predominantly, it also sells wild animals and farmed animals and other livestock, and they're all separated into different sections. So the wild animals are in one section of the market, the seafood is in another section, and they were expecting to find positive samples in the wild animal section because the virus is, from the phylogenetics, looks like it's very closely related to SARS and is originated from a bat or a mammalian ancestor, possibly with another intermediary animal. Pangolins have been postulated as a mammalian intermediary host. But surprise, surprise, they only found positive samples in the seafood section where the prawns and the fish are sold, which is interesting. Most cases outside of China have been travel-related cases who have travelled to China, but there's been 2 travel-related cases to date in Thailand. So people who travelled to Thailand, got infected and then went back to their home countries, who never went to China. Person-to-person transmission's been reported in a number of countries now, well documented, and there was one instance of 14 health workers infected by one patient in China, so it certainly seems to have the same super spreader ability that SARS had, that the occasional case might be much more infectious than other cases and infect a larger number of people. Case fatality rate, as Nick has nicely illustrated, there's a lot of uncertainty. Estimates range from 2 to 5%. Outside of China, though, it's much lower. It's under 1% outside of China. Even in Beijing, there was a case series published in The Lancet, I think, that looked at 13 cases in Beijing. They had no deaths. But if it's only 2%, you may not see a death in a case series of 13 patients. For ICU cases, in one published study, the case fatality rate was 38%, and for hospitalised cases, 11 to 15%. There is an unpublished case series in one of these repositories for pre-publications of 1,099 cases. That's the biggest case series to date, from 552 hospitals in 32 provinces, and that reports a case fatality of 1.36%. So this might be closer to the mark. And as Nick has outlined, it's less than SARS and definitely less than MERS coronavirus, less than the 1918 pandemic, maybe somewhere between there and the 2009 pandemic. So early on there seemed to be a male predominance in the cases, but as the epidemic went on, that difference disappeared and it seemed to be equally in females. Median age, depending on which publication you read, is 47 to 59 years. The youngest case reports have been in newborn infants, one who was documented as infected 30 days after birth. So whether or not it was truly vertical transmission or whether they got infected in the birth process from the mother, they don't know. This is that study I mentioned, the one that looked at the transmission dynamics, from which I think they made the best estimate of the R0. This is just interesting to see how the demographics changed before January 1st to 11th and January 12th to the 22nd. If you look at gender, male sex, it went from 66%, 59% to 48%, which is interesting. And the exposure to the seafood market decreased as the epidemic went along. Healthcare workers also 7% in the January to 12th to the 22nd. This is from another paper in JAMA, which shows some of the risk factors. Again, the gender difference was less pronounced than the early studies, slightly more males in ICU. And seafood market exposure was pretty low in most of the cases. Medical staff were significantly at risk, and people with comorbidities also were at risk, particularly any comorbidity, but particularly hypertension, cardiovascular disease, diabetes, cerebrovascular disease. One interesting feature that's come out in several publications is there seems to be a very long and mild prodrome where people just have a mild illness and they don't seek medical help. One study showed the mean time from symptom onset to seeking medical care was 5 to 6 days. So in a country with a low incidence, where there's a risk group that comes in, like we had the Tiger Airways incident recently in Australia, where a passenger was infected. If someone who's a contact is reporting very mild symptoms, I mean, they should be aware that they should be reporting mild symptoms. You need to take it seriously and test. The fever is the most common symptom, but it's not universally present. Dry cough, malaise, lethargy, shortness of breath, and myalgia, they're the most common symptoms. Less commonly, headache, productive cough, and diarrhea. Like SARS and MERS coronavirus, it's present in the feces and can cause abdominal and gastrointestinal symptoms. Mild cases can have a common cold-like syndrome, whereas the severe cases will develop acute respiratory distress and pneumonia. The mean time from symptom onset to hospitalisation is 9 to 12 days. So it's quite a long prodrome before people get severely ill, and that's been consistently reported. Other early reports suggest 50% have chronic underlying illnesses, about 21% go on to have severe illness. This is the first case that occurred in the US, and it's interesting because there's really detailed clinical data on this patient, and you can see that he began feeling ill. here on between day 1 and 2, he felt he had a fever. I think he didn't go to hospital until day 4, and the temperature then was 37.2. And then it shows the cough actually preceded the fever and was the earliest symptom, fatigue around the same time as the fever, and then the nausea, vomiting, diarrhea, etc. This is same study from JAMA of the 138 hospitalised patients, again showing you the prevalence of symptoms. 98% had fever, 69% fatigue, etc. And things like diarrhea, and diarrhea was only 10%, but other symptoms like dizziness and headache were occurring as well. The onset of symptoms to the median time to hospital admission was 7 days, to shortness of breath 5 days, to ARDS 8 days. And this just shows the pathology results. Basically, they get a neutrophilia, lymphopenia, prolonged prothrombin time. Some of them can get abnormal liver functions, and renal injury has also been documented. And this shows the complications. 8% had shock, 7% had acute cardiac injury, 16% had arrhythmias, 19% had ARDS, and 3.6% had acute kidney injury. They were treated with all kinds of things, ranging from antivirals to glucocorticoids to ECMO. That's the typical CT scan image of the ground glass appearance, the small fine opacities across both lungs. Not everyone has bilateral lesions, but it's quite common. In terms of drugs, vaccines and therapeutics, there are vaccines under development at the moment through CEPI. There's a group at University of Queensland that's involved in that initiative. There was a MERS coronavirus developed. It's not licensed anywhere, but maybe that will be, I don't know, the antigens will be adapted. At the moment, it's supportive treatment only, which includes obviously intensive care, oxygen, ventilation, ECMO. Theoretically, broad-spectrum antivirals might have effectiveness. It's reported that some of the HIV antiretroviral agents, lopinavir and ritonavir, used during SARS, are being used in China. There's no evidence of effectiveness in a systematic review from SARS. There are clinical trials of some of these antivirals at the moment going on in China. There's been no evidence of effectiveness of corticosteroids, but some of that might be a reporting bias in the sense that only the most severely ill patients are treated with steroids. We've looked at the complications. Phylogenetics, it's 88% similar to bat-derived severe acute respiratory syndrome like coronaviruses. SARS, it's 79% similar to, and MERS coronavirus, 50% similar to. And if you're following the phylogenetics, I'd recommend nextstrain.org, which is a really good site, and it's reputable. And if you hear about all the conspiracy theories about HIV and so on, just check this site, and that's been debunked. So there is a lot of misinformation out there. This is from nextgen.com, and it shows the relationship of this virus here, down here on the tree, to SARS, which is up here. So it's quite related. Although it's an RNA virus, which mutate more than DNA viruses, the level of diversity is still fairly low. I'll see if I can get this website up just to show you the so that's what it looks like now with the current, with 42 genome sequences in NextGen. So there's more diversity now, but the mutation rate is not as high as some other viruses. Now, how do I get back? So the key parameters, the incubation range is 1 to 24 days. But we often hear 14 days is the upper end. The mean incubation is 5.2 days, and that same unpublished case series suggests the median is 3 days. That was 1,099 cases, so it may be more valid. The range up to 24 days, R0 2.2, but some estimates are up to 6. The serial interval is 7.4. This just shows from that same New England Journal paper the distribution of days from infection to symptom onset. And you can see that there's a peak around 5 days and then a long tail to 21 days. Serial interval again around 7 days, but a long tail. And then they split up the cases before January the 1st and January 1st to the 11th to look at days from illness onset to first medical visit, and you can see it goes up to 12 days, and then days from illness onset to hospitalisation, which could be as long as 30 days. So quite a long, mild prodrome. Pre-symptomatic and asymptomatic transmission has been reported from China since early on. Nobody believed it until the German outbreak was published in the New England Journal. That was subsequently I wouldn't say discredited, but there was some controversy around it because the supposedly asymptomatic patient who infected the people in Germany, some other investigators in Germany contacted that patient and ascertained she actually had a backache when she was in Germany, and it was all very strange. But the Japanese study as well, for the Nishura study, which Nick mentioned, is also evidence for asymptomatic transmission or pre-symptomatic transmission. Children probably can transmit asymptomatically. This is the data from the German outbreak. So there's the index patient who visited Germany from Wuhan. Oh no, she was from Shanghai, I think. She was from China anyway. Then she flew back to China, and according to this paper, only developed symptoms on the plane. She infected patient 1, who directly interacted with her, and then patient 1 seems to have infected these 2 people who didn't have any contact with her pretty quickly after he got infected, which was interesting as well. This is from a familial cluster in Wuhan that was reported in the Lancet, and this case here is a 10-year-old child who was in a family of cases who had infection. And the child, for some reason, they did a chest CT, but he was asymptomatic. So an asymptomatic child had pneumonia on the X-ray, which suggests that, children may be able to transmit asymptomatically. In terms of all the epidemic modelling and predictions, we have, as I said, a range of estimates. I'd go with the Lee estimate of 2.2. That's really the best data used. We need serosurveys really to identify how much asymptomatic infection there was, because at the beginning when MERS first emerged, people were saying the same thing, that there's widespread transmission, we're just missing all this asymptomatic infection. But when the serosurveys were done, they did not support that. Even in camel handlers, the rate of seropositivity was very low. So we need that really So some of these modelling studies are saying the peak will be February. Some are saying it'll peak in April and kind of end in June. This is the study from Gabriel Leung and his group in Hong Kong, which I think some of the travel restrictions and quarantine decisions and so on might have been based on this study, which showed that the epidemic would peak around April and would continue on till about June, right? In terms of health systems impact, I'll just try and wrap it up quickly, but I think it could have enormous health systems impact. We did some modelling around smallpox, and we estimated that you would rapidly run out of people to do contact tracing. You'd have to use community volunteers. The capacity for isolation beds and ICU beds would be exhausted very quickly, which you've seen with pandemic flu anyway. Stockpiles generally last a few weeks, but these kind of epidemics may go on for 6 to 12 months. We estimated in that study that an epidemic going on for 6 months would require 30 million masks or respirators. So just to touch on briefly on guidelines for PPE for healthcare workers, they're different for different diseases and different between WHO and the US CDC, for example. Let's just look at the COVID-19. WHO is recommending a mask unless you're doing an aerosol generating procedure, but the CDC is recommending a respirator for healthcare workers in all instances and a mask for the patient to be worn as source control, whereas lab workers are recommended for a respirator. So transmission, you've probably heard lots of people saying with great certainty we know it's transmitted by contact and droplet. Well, we don't actually have the data to prove that. It is a respiratory virus. We know from several of the published studies that the viral load is much higher in the lung than in the throat. So an important clinical point for a suspected case is that serial throat swabs can be negative, and whereas if you try to get a sputum, it's more likely to be positive. So if you've got someone and you're really suspecting they're high risk of being a case, keep testing. If they're negative on the throat swab, try to get a sputum swab. And the fact that there's a higher viral load in the lower respiratory tract compared to the upper is consistent with airborne transmission. But the whole paradigm of contact, droplet and airborne transmission is an artificial paradigm that's driven hospital infection control practice for more than 60 years, and it's this belief that large droplets here in the blue will only travel 1 to 2 metres or 3 to 6 feet and then land on the ground, whereas larger airborne particles will travel further and will remain suspended in the air. And these are based on a very small number of experiments done in the 1940s and the 1950s using very blunt instruments. Newer research shows that both small and large droplets are present close to the patient. We know that healthcare workers are at risk of all infections: flu, meningococcal, measles, viral hemorrhagic fever, but almost 10% of Ebola and Marburg cases have been health workers. So droplet transmission, theoretically, if you believe this paradigm favours infection with the highest viral load in the upper respiratory tract, whereas airborne transmission favours infections with the highest viral load in the lower respiratory tract. We're told that influenza is droplet transmitted, but studies have shown that influenza virus can be present in air expelled through normal tidal breathing without even a cough. And we know for this COVID-19 that there's higher viral loads in the lower respiratory tract. In fact, today there was a news item saying that in Hong Kong there's evidence that infections may have spread from one floor to another in a particular building, which is reminiscent of the Amoy Gardens SARS outbreak in 2002. These are the studies that there are in the literature of horizontal distance travelled by droplets, so there's only a very few, and most of them show that droplets can travel much further than 2 metres or 3 feet, 6 feet. This is in feet here. So we'll have to think about dogma versus clinical complexity. You know, pathogens do usually have a predominant mode of transmission, but they can usually be transmitted by other modes. And experimental data don't account for the complexities in the clinical setting or inter-host variations or unpredictability in the clinical setting. SARS was definitely documented to be both droplet and airborne transmission. Surgical masks are designed to protect surgical wounds from infection and not proven to be effective at that. They're not designed as respiratory protection. They don't fit or seal around the face. Significant air leakage occurs through the sides, and they're not regulated on filtration. Respirators, on the other hand, are designed for gas, chemical and infections for respiratory protection. They are the air purifying respirators like the N95s or P2s, or the reusable ones that require batteries and cartridges. Air supplied respirators were generally only firefighters, etc. use. So the N95s or P2s are defined by their ability to filter out 95% of airborne particles which are less than 5 microns, generally less than 3 microns in size. They're designed to fit and seal and prevent leakage around the face, and their protection factors are 8 to 12 times greater than an ordinary mask. They have to be fit tested, but there's a wide variation in quality, mainly around the fit of available N95s. There's been very few studies of efficacy of masks and respirators, mostly observational or in vivo studies. There were studies done during SARS, observational epidemiology, which showed benefits of masks or respirators in protecting healthcare workers. There's only been 6 RCTs and only 4 comparing N95s and respirators. So this is a summary of the evidence, and basically the only studies that show anything is superior to anything else are these 3 studies that we did, which showed an N95 is, with a large number of healthcare workers are protective, but you have to wear it continually during the shift. The targeted policy of just saying put it on when you're doing an aerosol generating procedure doesn't work. These were the observed attack rates for clinical respiratory illness, influenza-like illness, any virus or influenza. For control in blue, surgical mask in red, N95 in green. You can see that it gets less and less. The targeted N95 use doesn't work. This was the other trial we did, which compared the targeted and the continual use of the respirators. This is a pooled analysis of all the data, and this just shows that even for infections that you consider droplet spread, so we looked at all the pathogens we isolated, classified them as droplet versus airborne. Even if it's droplet spread, an N95 or even a targeted N95 gives you significant protection, but a medical mask doesn't. I mean, the direction of protection is there for a medical mask, but you probably need a much, much larger set of data to show that there's protection there. However, when we looked at the continuous arm compared to control, the risk of lab-confirmed influenza was significantly lower. The risk of influenza was also lower in the medical mask arm compared to control, but the difference wasn't statistically significant. So in summary, there's a mixed bunch of evidence from observational in vivo studies. Observational evidence from SARS favoured the use of masks or respirators in healthcare workers. The RCTs generally show that the degree of protection increases from cloth to medical to respirator. I didn't show you the data from the only trial that's been done from a cloth mask, which we did, which actually shows that cloth masks increase your risk of infection. So it's probably because people don't wash them, they may absorb a lot of moisture. There's no good evidence for efficacy of masks in healthcare workers. Targeted use of a respirator is not as protective as continual use because the hospital's a highly contaminated environment and healthcare workers don't know when they're being exposed. And even for droplet infections, a respirator protects, but a mask doesn't. There's been no RCTs of the PAPAs and elastomeric respirators. I'll skip this in the interest of time and just, say that we need to look at more than just the mode of transmission to decide on guidelines. We need to look at uncertainty, case fatality. It matters more if you get the guidelines wrong, if the case fatality is high. You need to have consistency. Why would you have a different guideline for a lab worker and a health worker? Is there a vaccine or a treatment available? And what's the immune status and comorbidity of your health workers? What are the observations in the field? For example, in Toronto during SARS, they recommended masks and healthcare workers died. And then they changed their recommendation to respirators. That's just a risk analysis framework. Just to say that I think that the problems with the whole debate around respiratory protection is that hospital infection control has arisen around patient safety. So hospital infection control experts have always focused on patients, not on health workers. That's occupational health and safety. It's a different discipline. We need to bring those two disciplines together. So thank you, and also giving a plug for our journal, Global Biosecurity. Please submit your papers there.
Thanks, Raina, for that very comprehensive description of the emerging coronavirus epidemic and personal protection equipment. So we've got time for 2 or 3 questions. And we've got some roving mics, so please introduce yourself and ask your question.
Look, it struck me that obviously there's a lot of uncertainty around the the mortality rate here, because it seems to be still evolving. So the illness to hospitalisation time period seems like it can be very long, up to 30 days or something, as you're saying. And then this is just one case, but I read the article about the Wuhan ophthalmologist who I think was admitted to hospital on January the 12th and then finally died last week, which was another 3-week period potentially there. So that's potentially, 50 days if you take the top of each of those. So perhaps there's a whole swath of patients that may yet die, potentially from the cruise ship where it looks like there's none, but I think that's only been over a period of 10 days or so. So thoughts on that?
Well, there is high uncertainty, and it's going to be a while before we really pin those parameters down. Also, another complexity with China is at the various stages running out of test kits, and if health systems get overloaded, people don't get tested. So there's all those variables as well. So I think for the best parameters, we're going to get the data for cases outside China for some time yet, I think.
Raina, did you want to comment as well?
Yeah, I agree that the length of it seems to be a very long illness, and that could be clouding the whole measurement of case fatality. We just need to wait until more data come out with larger case series.
And there could be Chinese-specific factors. For example, air pollution is a big problem. China, most men smoke. 40% of the doctors smoke. So, there's a lot of underlying respiratory disease.
Alistair Neal, I work here as a respiratory physician. I've had an interest in pneumonia. And in the past, when there's been viral infections causing death with pneumonia, there's often a dual infection with bacterial following viral, but that hasn't been mentioned in any of the data presented so far. So I guess my question is, are other co-pathogens being considered as part of the cause of mortality from this virus?
I think I've seen some reports of influenza co-infection. I can't remember where, but there've definitely been reports with influenza. But I agree, the bacterial co-infection is an important one. It is with flu, and unless you look for it, you won't find it. And often, certainly in the 2009 pandemic, we did a systematic review of the bacterial mortality, and a lot of studies didn't even look at it. People weren't measuring bacterial infection. So that would be important to do.
Hi, my name's Carol and I work in infection control here. I wondered what your comments were on eye protection.
So as you know, there have been reports of the infection being transmitted through the eye, conjunctiva and so on as well, from people who wore appropriate respiratory protection but had their eyes uncovered. There was one case, I think, where the patient reported, who was a healthcare worker, I think, reported that he developed red eyes and painful eyes as well prior to becoming ill. I don't know if that's proof that he got it through the eyes, but I would say eye protection would be important.
I think there seem to be a couple of points here. One question in particular is the quality of data that we have coming from China. And the second might be a question around I'm not sure if you're in a position to answer this one, about the availability of personal protective equipment in Australia and New Zealand. So do you want to comment on those two?
Well, I can agree that, yes, we should be very sceptical of the quality of data from China. And as I said before, we should perhaps focus more on the cases outside China where we can get better quality information. And really in response to that other question, New Zealand does have a strategic stockpile of protective equipment, but maybe others can say how large it is, but we do have some stockpiles.
Right, I'm conscious of the time, so we'll maybe I know we've gone a bit over time. Are you happy if we just take 2 more questions from the audience?
I'm Sally Talbot, I'm in primary care, and I've been very concerned about the PPE issue in this country, and I've been running a survey online in a GP to GP group, and many of us do not have adequate PPE gear, and I know in Wellington we've asked the DHB to give us some of their stock, and currently we've been told no. So many of us do not have adequate respirator masks or goggles or full gear to wear right down to the arms and down to the legs. So we are not fully prepared, and when you get colds and flu, you present normally to your GP. So we are quite concerned.
would you like to comment on how this should be managed in the primary care setting? Raina, is this something that you've come up, and I mean, I guess it's come up a lot in Australia as well.
It has, it's been controversial. I mean, I think it's really hard for primary care because, ideally you need to have a system with your triage, that your receptionist has PPE, and that you've got somewhere you can put someone if you think there could be a suspected case, that you should be getting your receptionist to ask everyone with fever, have you travelled? Make sure you get the travel history, and then if you think someone's come from an affected area, could have the infection, place them somewhere away from your waiting room and other people, contact your public health unit or your health department, and that's what the advice has been in Australia. Of course, in Australia, they put in a recommendation, if you think you've got coronavirus, contact your GP, but call ahead first. So the minute you put a recommendation in like that, then, GPs... so I'm not sure what the recommendation is in New Zealand.
It's called Healthline initially, before, don't just front up to the GP or the emergency department. The speakers will be in the foyer afterwards if you want to catch up with them, and we really appreciate all of you being here, and I think the huge collective effort being carried out in New Zealand and internationally. And a huge thank you to Raina for coming to New Zealand and giving up 2 precious days to really share her expertise with a number of people today and also tomorrow at the Ministry of Health. So thank you, Raina.